Good morning, everyone. My name is Griffin Smith from Metro Trains Australia, and I'd like to thank you for joining our February Community of Practice. This webinar focuses on the overview of changes following the recent release of the National Standard, presented by Josie Thomas from the National Transport Commission, medical updates in the RIW system presented by Daniel Redman, and I will take you through the changes of the approved AHP list as well. I'll get Josie to present the first.
Thanks, Griffin, and good morning, everyone. Before we begin, I'd like to acknowledge that I'm presenting this briefing from the lands of the Yorta Yorta people. I acknowledge the traditional custodians of the various lands on which you all work today and the Aboriginal and Torres Strait Islander people participating in this call. I pay my respects to elders past, present, and emerging. Thanks to the Rail Industry Worker Group for inviting me along today to provide you all with an update on the National Standard for Health Assessment of Rail Safety Workers. As Griffin mentioned, my name is Josie Thomas and I'm the Project Manager at the National Transport Commission for the review of the Rail Medical Standard. Today we'll go through the recent changes as well as some changes to the RIW system and the AHP program. For those of you who weren't involved in the review of the Rail Standard, here's a timeline of the process. So the review ran for almost 2.5 years with extensive input from our stakeholder groups. In October 2024, we received approval from Transport Ministers and we published the standard, as well as other education and support materials to assist with the transition to the new standard. The new standard commenced on Monday, the 11th of November 2024, and all health assessments are now being performed under the 2024 edition of the standard. Authorised health professionals have been briefed on the changes and new AHPs can now complete online training, and Griffin will speak a little bit later about these changes. In terms of consultation, we undertook a comprehensive set of activities, including the following. We had a robust consultation process with advisory groups, information sessions, and individual meetings with our stakeholders. From the beginning of the project, we established a Rail Health Advisory Group with members nominated from ONSA, RTBU, operators, government departments, and chief medical officers. These members reviewed and provided advice on the various issues and versions of the documents. We discussed and resolved issues at the Rail Health Advisory Group level and escalated to the Chief Medical Officers Council, the CMOC, and medical specialists in the fields of cardiovascular, diabetes, sleep, hearing, vision, and neurodevelopmental disorders. These specialist bodies have all endorsed their respective chapters in the standard. We also worked closely with the regulator, ONSA, to discuss and resolve issues, and we had detailed input from the Rail, Tram and Bus Union, the RTBU, and the Australian Manufacturing Workers Union, the AMWU. We ran information sessions on the changes for operators, including sessions for large operators and for the tourist and heritage sector. We've also received feedback that the rail standard is considered best practice in the international transport medical space, and we've provided advice to the UK RISB on their rail standard, as well as in Australia on the maritime pilots and coal industry services. In terms of implementation of the standard, we work really closely in partnership with RISB and the AHP program on a communications and education plan. The NTC has delivered a consultation report and summary of changes to easily refer to and understand what the changes mean, 2 fact sheets, one for workers and one for operators, which were developed with input from the AMWU and the RTBU, and these are available on the NTC website. We also prepared a stakeholder information kit, which included key messages for different audiences to advise about the release of the standard. And in partnership with RISB and the ARA, we're also finalising a suite of 26 health risk assessment examples, and these will be published in late March. They'll be a useful starting point to undertake a health risk assessment and categorisation for various rail safety roles. We also worked with RISB, the AHP program, and the chief medical officers to develop 2 training options for new and existing authorised health professionals. I'll start by going through the changes proposed in the medical chapters and then focus on the administrative aspects. So based on the feedback we received, we made changes to the chapters on cardiovascular conditions, diabetes, hearing, neurodevelopmental disorders, sleep disorders, and vision. And we didn't make substantial changes to the chapters relating to blackouts, musculoskeletal conditions, neurological conditions, psychiatric conditions, substance misuse, and dependence. So what has changed for workers for cardiac risk? This chapter was revised with input from the Cardiac Society and reflects developments in the screening, assessment, and management of cardiovascular conditions. It now includes the new version of the Australian Cardiovascular Risk Calculator, which is applied for Category 1 workers. The new cardiovascular risk calculator is specific to Australia and takes into consideration information that the previous tool, which was published in 2012, hadn't. It's considered to be more accurate with an improved ability to identify people at risk of a cardiovascular event in the next 5 years. It won't be applied to workers under 30 years of age. Workers who are assessed as being at high risk of a cardiovascular event will be referred for an assessment by a cardiologist. Routine exercise stress tests will only be conducted on the advice of a treating cardiologist, and this should reduce the testing burden for all parties and is considered clinical best practice. Fasting is no longer required for pathology tests. For cardiac risk score, this has been the case since 2022, but has been updated to reflect that. Workers with existing cardiac conditions, the test previously described for initial fitness for duty, an annual review, such as the exercise stress tests I mentioned, will only be performed on advice of a cardiologist, and that should reduce the burden further. And the review periods for Category 1 workers are now annually in line with other standards. So in terms of diabetes, workers won't need to fast for pathology testing, as I mentioned. We know that diabetes is a condition that's underdiagnosed in the community, and it's estimated that at least 3 in 10 adults with diabetes in Australia are undiagnosed. Up until now, diabetes in Category 2 workers has been identified by self-report, while Category 1 workers undergo screening via a blood test. This means that diabetes might have been missed due to lack of screening in Category 2 workers. Under the new standard, Category 2 workers will undergo screening via a urine glucose test at the time of their assessment. This won't require fasting. Changes to the requirements for specialist reports for workers with diabetes will also be beneficial for workers. So this relates to workers treated with metformin and treatments other than insulin. So, for example, a Category 1 or 2 worker with diabetes who are treated with metformin alone may have their initial fitness for duty determined based on a report from their treating doctor or GP. And if their diabetes is satisfactorily controlled, subsequent reviews may be conducted by their AHP based on their HbA1c levels. For workers treated with oral agents or injectables other than insulin, the initial determination must be made on a report from the specialist, but subsequently a report from the treating GP may be acceptable where a worker has demonstrated a significant period of satisfactory control. So all workers on insulin must be reviewed annually by a specialist, and that remains unchanged. In terms of hearing changes, Audiology Australia was involved in the review of the hearing chapter, which now takes into consideration that even mild to moderate hearing loss can affect a person's ability to hear speech in a noisy environment. The original recommendation of a reduced hearing loss threshold of 35 decibels for fitness for duty, and the threshold that was not accepted during our consultation. So the threshold will remain at 40 decibels due to lack of evidence of the impact of hearing loss on the rail safety task. However, the assessment will now take into consideration the worker's self-reported hearing loss or communication issues and any workplace reports to ensure that hearing loss is appropriately managed. The interface with operators' hearing conservation programs has been strengthened in this version of the standard. So all workers with hearing loss greater than 20 decibels will be counselled regarding their hearing conservation measures and referred to their GP. The AHP will communicate concerns regarding the impact of workplace noise exposure to the operator in their report so that the worker can be managed under the conservation program adequately. Stakeholder feedback during consultation pointed to concerns regarding assessments in relation to musculoskeletal requirements. Examples were given where workers were being assessed as fit for duty when they were off work with an injury. Workers felt that they were being assessed at levels that were not consistent with their roles, that is, demonstrating functions were in excess of those required for the function. A working group was established with representation from operators, health professionals, and the union. It was determined that the chapter itself set out the requirements accurately. The gap appears to be in implementation, with health professionals not tailoring the assessment to meet the task requirements. And it was concluded that this could be addressed through the AHP education, but also that operators proactively communicate the musculoskeletal requirements so the assessment can be tailored accordingly. We've therefore made changes to the request and report form, the record for health professional, and the health risk assessment template to provide more space to record the musculoskeletal requirements. This is a new chapter which was specifically developed to address neurodevelopmental disorders such as autism spectrum disorder and ADHD, which were not well covered by the other neurological disorders content in the standard. The new content has been well received as it provides detailed guidance around the potential and variable impacts on rail safety. And there's also now mention in this section around prescribed drugs that while stimulant medications prescribed to treat ADHD are unlikely to result in impairment unless there's abuse, they're likely to be detected in a random drug test, and workers should be advised accordingly. We note that sleep disorders are common and pose a significant risk to rail safety, and this has been highlighted in recent New South Wales research linking obstructive sleep apnea to rail incidents. These conditions result in impaired judgment and increased sleepiness, and we know that there can be effects on your thinking ability well before you experience any sleepiness. The revised standard now includes a new assessment tool, which is administered by the AHP, which is the Stop Bang questionnaire. This assesses a number of risk factors, including snoring, tiredness, whether someone has observed you stopping breathing, choking, or gasping in your sleep, high blood pressure, age, neck size, and gender. It results in a score that helps determine when a worker should be referred for a sleep study, and this results in a more consistent approach to risk management and assessment. The Epworth Sleepiness Scale will still be used because that identifies actual sleepiness, and it's acknowledged that the new approach will result in more workers being referred for a sleep study initially. However, repeat studies will not be necessary unless there is a change in risk factors between assessments, and workers will also be able to have level 2 sleep studies at home. We've been conscious to address the burden of attending sleep specialist appointments. So in some cases, the AHP may undertake the review for workers if there's an established pattern of compliance and successful treatment. So more in-depth training for AHPs will equip them to do this. In terms of vision, under the previous edition, all workers were required to be categorised fit for duty subject to review if they wore corrective lenses, irrespective of the stability of their condition. They would also be fit for duty conditional on wearing lenses at work. The requirements have been revised to avoid unnecessary review. Unnecessary review, but also to ensure that those with progressive conditions are regularly monitored. So workers with stable visual acuity that meet the standard with the corrective lenses will now be categorised as fit for duty unconditional with review of their vision at their next periodic assessment. They do need to wear their lenses while working, but this won't be identified as a separate fitness for duty category. It will be identified on the fit slip. Similarly, for visual fields, Workers who currently meet the visual field criteria but have a progressive condition that is likely to affect their visual fields, they'll be categorised as fit for duty subject to review so that their progression can be monitored. There has been some refinement in the visual acuity section, including removal of a flowchart, which had become a little bit difficult to interpret, and new content has been included to address laser surgery and includes consideration of non-working periods and refers to potential effects such as sensitivity to glare, starbursts, and double vision that might affect fitness for duty in the short term. There's not been a change as such, but we have clarified the messaging, particularly as it relates to weight loss medications and medicinal cannabis, as stakeholders sought clarification about guidance on prescribed drugs. So the standard now lists the 3 drugs that are defined in the Rail Safety National Law to remove any doubt. Until there's a change in the law supported by strong evidence, the standard can't allow for workers to be carrying out rail safety work, even if they had a valid prescription for a prescribed drug. In more recent months, while we're giving consideration to the authorisation of the health professionals, it became evident that AHPs conducting Category 3 assessments could be called upon to make decisions in relation to medical conditions declared by the worker, such as epilepsy, cardiovascular disease, and diabetes, which was in line with the incorporation of the RISB technical note. So given that these AHPs aren't required to be medically trained, consideration was given to the implications for the fitness for duty reports. So the standard now requires that these non-medically trained AHPs conduct the assessment under the supervision of a medically trained AHP. So they're not able to sign off on the fitness for duty of workers with these particular medical conditions, and this has been communicated through their training as well. So it's in the interests of workers and operators that assessments are conducted to a high standard and by a health professional who's appropriately trained and authorised. You might recall this was a key recommendation from the Waterfall inquiry. During the review, we received feedback from stakeholders as well as data that indicated issues with quality and consistency of AHP decisions. Feedback suggested that many non-AHPs are conducting assessments which are either being signed off by a single AHP or signed off by a non-AHP, such as the worker's GP. That's not the intent of the standard, so we hope that these changes, along with the new AHP program, prevent these issues from reoccurring. The standard now clearly states that only AHPs authorised according to the standard may conduct health assessments. We've included an explicit exemption to this requirement where a chief medical officer may determine that lack of access to an AHP, such as the worker being in a remote location, may prevent them from having a medical on time. The CMO will need to sign off on the fit slip, and this will be recorded and monitored by the AHP program. This information will be shared with the NTC and will allow us to monitor implementation between formal reviews. We've also included content to state authorisation is only through the AHP program and that AHPs must pass training and be registered. Part 2 has been updated to include more explicit descriptions of the roles and responsibilities of a Chief Medical Officer, including the power for the Chief Medical Officer, with the support of the operator, to extend a worker's medical by 1 month. This should be limited to exceptional circumstances, including not having a medical report in time or the worker being off sick at the time that the medical is due to expire. And this provides some flexibility to prevent workers from being stood down with an expired medical. Union representative feedback identified that while the original 2017 standard identified that operators needed to provide reasonable notice for health assessments, there was a lack of a definitive time frame, which meant that this was quite open to interpretation and not consistently implemented. So Part 2 has been updated to include a minimum notice period of 10 working days for periodic and non-urgent triggered health assessments, unless varied by mutual agreement between the operator and worker. As I mentioned earlier, we've now got 4 fitness for duty categories: fit for duty unconditional, fit for duty subject to review, temporarily unfit for duty, and permanently unfit for duty. So the categories of fit for duty conditional, which was applied for workers needing to wear corrective lenses, hearing aids, or other aids, has been removed. And workers are still required to wear these aids, but that will be identified on the fit slip. And if a worker has a stable vision condition, they'll be categorised fit for duty unconditional. Hearing loss is not considered to be a stable condition, so workers who require hearing aids will be categorised as fit for duty subject to review, and the frequency of review will be determined on the nature and degree of their hearing loss. And we've been advised that generally hearing aids are expected to have a 5-year lifespan. Consultation with our union representatives identified that workers were unclear about how their concerns or complaints about the health assessment process could be addressed. We've included additional content about the avenues available to workers if they disagree with an outcome, or if their health assessment, they've got a complaint about how the health assessment was performed. So the new content outlines a complaints mechanism whereby a worker discusses their concerns with the AHP in the first instance. They may also request a review by the Chief Medical Officer or the rail transport operator. The Chief Medical Officer's Council can play a role in resolving these concerns, and the worker may also seek input from one of their treating doctors or a specialist, or a second opinion from another AHP. So complaints about AHPs can be lodged with the AHP program, and the details are included in the standard. This slide just lists the sort of key changes around privacy and health management, and we've just sort of clarified existing content to emphasise that workers are entitled to access their health records under Australian privacy law by making a direct request to the medical practice of the AHP. And all these slides will be shared, so don't feel the need to take notes or screenshots. In terms of forms, there's been quite a few changes to the forms to promote usability, address where common errors have been made. So the suite of forms will provide, or we hope provide, quality and consistency, and should be used where operators are using the model forms. We recommend that they're sort of always downloaded from the NTC website. We've got PDFs here as fillable versions, but if you do need Word versions, please reach out to the NTC and we can provide that as well. So the finalisation of these forms has involved extensive consultation with chief medical officers, the RIW program, operators and unions. And in Appendix A of the summary of changes, we've got some guidance around what the key changes have been across all the documents. And I've just pulled out the request and report form here for you to look at. Might be a little bit difficult to read, but essentially the screenshot on the right shows the fit slip, which I've referred to throughout the presentation. And this was updated to reflect changes to the different categories, as well as on the right-hand side, additional boxes to highlight what the next steps and timing around those are. And also down the bottom, there's now 2 different boxes to indicate whether the decision has received oversight by another AHP or a chief medical officer. And all the criteria on this page has been updated and mirrored in the RIW system, and Daniel will speak to that next. We're also working with the RTBU to prepare some guidance for Category 3 workers who self-initiate health assessments due to being in a self-employed contractor role. So once this guidance has been finalised, it will be available on the RIW website as well. And one more thing to mention, printed hard copies of the standard will also be available for purchase from CanPrint as of next week. So I think they're sort of the key things. Thank you for your time, and I'll now hand over to Daniel to go through the RIW system changes.
Well, thanks, Tracy. Yes, I'll just briefly touch on the RIW system has adapted to the revised standard. So I'll run through the RIW medical form, also how the health assessment report, the Part B fits slip, correlates with the RIW system. I'll also go through some work restrictions which have been updated. Additionally, I'll go through the expiry logic, considering some of the changes that have occurred in the new standard, as well as how system notifications support the clarification around the notice period for periodic medicals. And lastly, I'll just give a quick review of medical record visibility. So who gets to see what in the RIW system. So with regards to the RIW medical form, authorised health professionals, where they've elected to have direct upload capability, can directly upload medicals into RIW. Alternatively, medicals are submitted via a service request to our service desk, who then upload the medical into the RIW system. So a fit slip would be produced, and then that translated into RIW. So some of the key changes that have occurred in the RIW medical form is some of the terminology, which I'll go on to the next slide, but just some examples is where the medical result is now referred to as the outcome. Examination dates now aligned to the fit slip, showing assessment date. And importantly, medical level is now assessed medical level. I'll go into why that's important. There's a new field which has been included, which is worker category. So this indicates the level of medical that the worker is originally being assessed for. That may and can be different to the assessed medical level. So an example would be a worker is undertaking category 1 work duties and is going in for a medical, and they're going in with the intention to be assessed as a category 1 worker. However, during that assessment, the worker may be deemed unfit for category 1 or unfit for category 1 and 2, but fit for category 3. So in that case, the worker category would be still captured as category 1. However, the assessed medical level would be recorded as unfit for category 1 and 2 and fit for category 3. With regards to the logic and how that works with RIW, the worker category doesn't drive any job role validity. It still remains the assessed medical level. So in the case that a worker is fit for duty for category 1, that will validate their category 1 classified job roles or any requirements that require category 1. If the worker is a worker category 1, but unfit for category 1 and 2, and fit for category 3 under the assessed medical level, in that case, the worker would be unfit for category 1 job roles, but any job roles that require category 3, those job roles would be validated. There's also the addition of examination conducted by. So in the majority of cases, that's going to be the AHP that perform the health assessment. But with some of the changes in the standard, that may be another medical practitioner which can be recorded. So most of the time, it's going the examination conducted by is going to be the AHP, the authorised health professional name as well. Just looking at some of the changes. So the date of AHP assessment is assessment date in RIW. Worker category is new. Type of assessment hasn't changed. Outcome, as Josie touched on, and there's now four categories. Just for employers and network managers that may not be aware. So the logic in the system is that these changes have been updated based on the effective date of the new standard, so the 11th of November. So where a medical is being loaded into the system with an examination or an assessment date of before the 11th of the 11th, so underneath, conducted in accordance with the previous standard, the outcomes conditional and subject to job modification will still appear and can be recorded accordingly. So it's only medicals that are being conducted since go live of the new standard. The system aligns the options with the new standard. The assessed medical level. So we've got category 1, 2, or 3, and also unfit for category 1 and 2, but fit for category 3, and then also unfit for category 1, 2, and 3, but fit for work outside the danger zone. There's been no changes to the colour vision options, and the expiry date when recording it in the system is auto-populated periodic medicals. And I'll touch on in the next slide around some of the rules and exceptions to the standard expiries. And subject to review is a manually entered date as per previously, which would be indicated on the fit slip, the next date of review. I'll just touch on work restrictions next. So the list of defined work restrictions have been updated. Where a work restriction that is not on the defined list, other and see details in notes would be selected with details of the work restriction noted in the notes section on the form, on the online form. One area that's been updated is fit for duty subject to job modification. So subject to job modification has is no longer one of the 4 hard categories. However, subject to review, subject to job modification can be indicated on the fit slip. In that case, we've actually included subject to job modifications as a work restriction. Based on some feedback from several network operators, they were still wanting to identify whether there were job modification, whether the worker was subject to job modifications, and that can now be captured through the work restrictions. Work restrictions are also reportable in RIW under the people, medical, and then specifically work restrictions tab in reporting, and that's for employers and network operators. Workers can also see the work restrictions that have been reported against their profile in their My RIW profile, so their access. Another item that's been included in the work restriction area, where it's not specifically a work restriction, but for reporting, is referral to a hearing conservation program as one of the changes in the revised standard. Employers and network operators can now monitor any ongoing management of hearing where a worker's been referred to a hearing conservation program through work restrictions. With work restrictions as well, employers can monitor that, one through reporting. There's a dedicated work restrictions area in RIW where you can view all workers' restrictions with relevant dates and review dates as well. Just going on to expiry logic. So in line with the standard, the RIW enforces the mandatory maximum expiry dates for medicals recorded within the system. So for periodic medicals and category 3 are valid up until the worker's age of 40 and then every 5 years thereafter. For category 1 and 2, they're age dependent, so depending on the age of the worker. There's been no material changes in that regard. Just with subject to review, just to note, the system won't allow a medical to be reported with an expiry date longer than the natural expiry date of what that medical is, whether it's a category 1 or a category 2 or 3. And the expiry date would be the review date as recorded on the fit slip. And that would be reported as the expiry date. Just with a couple of additional rules. So With regards to Transport New South Wales, so they require Category 3 medicals to expire every 5 years, irrespective of the cardholder's age. Therefore, when a cardholder holds a Transport New South Wales specific job role, that job role expiration will be set as five years from the date of the medical. One thing to note is that the medical, because it's a national program, the medical may have an expiry date longer than the 5 years. However, the job role may not be valid. So I know that we have had several queries come up going, the worker's got in the system, it looks like the worker's got a valid medical. The medicals hasn't expired, yet the job role's not valid, but they meet all the competency requirements. With Transport for New South Wales, this is the underlining rule for their job roles. So newly added to the new standard, when scheduling periodic health assessments, rail transport operators, network operators may apply a fixed anniversary date, provided that the assessment is conducted 2 months or less before the expiry date of the worker's current medical. So just to give an example of how this works in practice is, if the worker's medical expires, say on the 31st of December, at the end of the year, the worker can have another medical done within 2 months of that date. Let's just say they do it at the end of November. And then the expiry date of that medical, rather than being the natural expiry of 1 to 5 years, would actually be the 31st of December in whatever the relevant period is. I will note, so this is, it's important to note that network operators may choose this. So currently there's 2 network operators that do not apply this fixed anniversary logic, being MTM and Beeline. So this logic doesn't apply to workers who are primarily employed by those 2 network operators. There's also another change is a chief medical officer, with the support of the RTO, can extend a medical report by up to 1 month. So how that would work in RIW is that a new fit slip would be produced and then recorded in RIW. Just touching on expiry notifications. So in part of the standard, as Josie said, the minimum notice period for notifying workers around medicals is now 10 working days. So the RIW system automatically generates notifications for medicals approaching and surpassing their expiry date. Email notifications are triggered at set 12 weeks, 4 weeks, 1 week, and day of the day that the medicals expired. Employers and network managers can elect to receive medical expiry notifications, and they do that through logging into RIW, going to My Account, and then communication preferences. Workers can also elect to receive these notifications as well, and in order to turn that on, they would go to their My RIW account, manage their account, and change notification preferences. Workers can elect to receive these notifications either via email or Verkada, where they've had a virtual card issued, or both. I will note though, so all notifications are turned off by default. So employers can update workers' notification preferences within RIW under status options, but the worker has ultimate control over their notification preferences. Notifications for employer admins as well are also defaulted to unselected or do not notify. So it may be for employers and network operators who are wanting to ensure that their workers are getting notified of expiring medicals. It may be worth having that conversation with workers around how to opt into these notifications. or activate them on behalf of the worker if you've got permission. Lastly, I'll just give a really brief overview on medical record visibility. So medical data in the RIW systems managed to balance privacy considerations with operational requirements. Authorised health professionals, those with an AHP login to the RIW system, has full access to all medical records for a worker to ensure a comprehensive assessment and compliance with regulatory standards. AHPs also have access to the underlining and uploaded Part B health assessment report, the fit slip, relevant to the record. Employers and network managers are only provided access to the most recent medical record for a particular assessed medical level. So if a worker has has a Category 1 and a Category 3, then there would be two medicals that would surface. So this represents the current and relevant health status of the worker. RIW workers and cardholders also have access to all their medicals are reported against their profile. However, they don't have direct access to their Part B health assessment report. However, that is it is available on request. There's a service request through the RIW website for workers to request a copy of their fit slip if they need. So that's just a quick summary of some of the changes and how changes in response to the new standard. So I'll pass over to Griffin to give you an introduction on the revised and the new AHP program.
Thanks, Daniel. Thanks, Josie. During the review of the 2024 National Standard of Health Assessments of Rail Safety Workers, the National Transport Commission, Rail Industry Safety and Standards Board, and the Chief Medical Officers Council took the opportunity to improve the quality, governance, and assurance of the AHP program. As of the 11th of November, the AHP list has officially moved from the RIW website to the AHP program website. The new directory is now live and accessible. It is important to remember that all rail medicals must be conducted by an approved AHP who is listed on the AHP program directory. Any medicals submitted to the RIW program must be signed by an approved AHP, otherwise the medical will be rejected by the RIW service desk. The AHP program provides the rail industry with confidence that all rail medicals meet a consistent high standard, which is governed by RISB, NTC, and CMOC. To maintain accreditation, all AHPs are required to comply with a yearly training and assessment, ensuring they remain qualified and listed on the AHP directory. This change strengthens the integrity of the AHP program and reinforces our commitment to safety and compliance in the rail industry. Thank you, everyone.